So I will be talking on easy to miss, challenges to fix, neglected locked posterior dislocation of the shoulder. So not very common scenario, and we normally once or twice in a year we see some patients coming with second or third opinion with pain and restriction of movement of the shoulder. So why often we miss it, Roshan boss? Such type of patient you see. Can you see on
Posterior dislocation is often missed.
Yes.
Because one, the surgeon is very complacent that he is the most intelligent person. He doesn't need the other view. You should always take other view. And sometimes people are unable to catch that light bulb sign, which is evident, but
So
they don't
So he was roaming around
accept
with
it.
this X-ray.
Yeah, so this is what I said. People will accept this.
So with this X-ray, why people miss the anterior posterior dislocation?
So that is why we have to train more and more people. That
So reason is that with posterior dislocation, what happens normally with anterior dislocation, you have a classical empty glenoid sign. You will see a glenoid, the head is running down. But in such type of patient, normally we miss doing one more view. That is your overview view or axillary view, and that will guide you. And when you are getting such type of patient, it's very important to have a CT also, because that will not only help in your planning also. This will help after procedure. You will go for bony procedure or like that. So this
Rajeev,
is my first question. Yes.
Yeah. So before,
Can I just
Yes,
come
sir.
to why this is missed?
Yes, sir. Very common question, sir.
So acute injury, patient is in a lot of pain. You do an AP view, it looks kind of normal. This is grossly abnormal. I would show you X-rays where it is looking absolutely light bulb sign, absolutely normal, and you cannot easily do a lateral view in an acute situation.
Yes, yes.
So this is where you get caught. So I think one thing that I tell my fellows is, so-called inverted commas soft tissue injury shoulder, a sling, go back, do physiotherapy, you will be all right in 3 weeks. If that does not happen in 3 weeks, that means your shoulder is still stiff. Look at it more carefully, do another X-ray, do a CT scan. All soft tissue injuries, so-called soft tissue injury, X-ray looks normal, the shoulder should recover very fast, within 2-3 weeks. And usually that does not happen, and they go on physiotherapy, keep doing it. That's where the problem is.
That is the reason, and the patient roam around with pain and restriction of movement.
So can I, before you talk about X-rays, I think one important clinical sign which nobody is not written in books and don't see is, this is my thing, I just do this and I've identified a dislocation without touching the X-ray at all. Simple thing, put your hand on the shoulder, feel for the back of your shoulder. If you feel something hard behind your acromion, it is dislocated.
So very
That
good
is the
point.
only test you require.
Yes.
And that is what will diagnose this problem.
So very good point. So standard literature is, so if it is less than 3 weeks, you have humeral head bone loss of less than 20%, and in a fresh case, you can try general forward flexion, internal rotation and reduction, a gentle push from back, and sometime it gets reduced. So that makes your life easy, but always do it as Dr. Roshan told, after doing a proper CT scan and MRI. Yes.
have you done CT and MRI here?
What I usually
CTL.
do is I do a close reduction, but it's going to be an assisted close reduction. Okay, assisted close reduction means I'll use a small wrench posteriorly and use my periosteal or something like that.
yeah,
To
or
lift
use
it
a
up.
shan screw or something,
something,
and then
yeah.
something.
Yeah, that's what I do.
So for 6 weeks, we had options B and C: open reduction with subscapularis transfer, open reduction with lesser tuberosity transfer. Roshan, what would you prefer in this case?
I told you, first I want to see the CT and MRI.
CT, I told you, na? CT is there, yes.
CT is there, MRI.
MRI is not there. Sorry.
I think the CT has sufficient information for you to answer, Roshan.
So for this, I want to see the more of a 3D in the humeral head compression, amount of anterior bone loss, how much of bone loss is gone.
Between 25 to 30%.
25 to 30% of humeral head is gone. So in that case, I will do a modified McLaughlin, that is do osteotomy of lesser tuberosity and shift it inside.
So this is very good option. So if you have less than 25% bone loss, the soft tissue subscapularis transfer will work. But if the bone loss is more than 25 to 50, up to 40%, I think you should go for a bony transfer. For bone graft, when do you plan for bone graft heartbeat?
More than 50, big
So,
graft.
and
or maybe
young age arthroplasty, I think it's a big no. Yeah, so big no. So we have a very good review article in effort. If you see decision making for treatment of lock posterior dislocation. So less than 25% bone defect. So if it's an stable, close or open reduction. Close reduction is only, as I told you, less than 3 weeks, and you should, humeral head bone loss should be less than 20%. If it is unstable, yes, you can go with isolated subscapularis transfer with the transosseous suture fixation. This is the gray area, where the main area, because most of these patients we get is between 25 to 50%. So here we have to go for some bony procedure, because what happened with the subscapularis transfer, you can't fill the bone defect. So you go for lesser tuberosity osteotomy and you can fill the defect. Rotational osteotomy has been described in literature, few of us do it. And if your bone loss is more than 50%, and you have two options, elderly patient you can plan for orthoplasty, but young patients either a allograft or a autograft reconstruction. So any different opinion, any suggestion from Vivek? Yes.
So in bony reconstruction cases, I think it has been published about the osteoarticular bone graft reconstruction. So that we do not have. So we have only the. So how does it fare compared to the osteoarticular filling, compared to just a bone filling?
Osteochondral allograft has got very good result, especially the BioUni or osteochondral allograft in knee. About shoulder, I don't have personal experience. Maybe we can ask our European colleague, or Andy, you have experience
I think
of
Kapil,
osteochondral
Kapil
allograft in
yes.
shoulder joint. Osteochondral allograft. Yeah, Kapil.
Rajeev, just a quick question about the pure subscap transfer. Are you suggesting that you peel the subscap off from the lesser tuberosity and you transfer that? Or I've never done that, and hence this question, because anytime I've always taken it with a lesser tuberosity and fixed it, you've got a more robust fixation. So just a show of hands, do people do that little thing in the less than 25% as subscap transfer? What do you mean by that? Is it a soft tissue transfer, or you take it with the lesser tuberosity?
You take a peel of bone also, and but it's not an osteotomy, because you just fix it with a transosseous suture. That is the minimal amount of bone loss over the humeral head.
Just like a
But that was a
remplissage.
McLaughlin procedure, classical.
Yep.
He was not using he was not he was not doing
In fact,
osteotomy of the lesser
people don't
tuberosity.
knock off the tendon.
Yes.
You just put an anchor in the lesion and just tie the tendon there. It's like a
Anterior remplissage.
tenodesis.
It's like an
It's like a
anterior
tenodesis. Anterior tenodesis of the subscapularis.
So regarding allograft, I think there's a question regarding allograft. So allograft, I
So
think it's not.
we just wanted to know from our European colleagues, you have any structural allograft, osteochondral allograft, not the, or Andy, you have any experience? Osteochondral.
I'm not working that long, but I've done 2 cases with osteochondral allografts, and they do well, but it's only 2. So
Limited number.
yeah.
So that's what is my question, is we do not have osteoarticular allograft. So what we are limited with is, it's a pure bone. So will it lead to some stiffness? That's my question.
Yes. So
In Singapore, I think the grafts you get, even though it's osteochondral, I think it, with the shipping and all that, I think the
Yeah, it's available from MTF.
Yeah, survival is different. So in those cases, what I've done is I've actually preserved the patient's native cartilage, which sometimes you still see, and then I take I like try graft and try and build that up as much as I can, and I retain the patient's cartilage and I fix it down.
For knee, we have good experience in this thing. For shoulder, I don't know any of
Anthony,
Indian
your
surgeons have
comments?
used osteochondral.
It's a good case, but we have some experience with defect in the glenoid, with the costal bone or tibial autograft.
Tibial allograft.
Yeah, tibial allograft. But in this case, I think it's big for it's bigger for the cost, for take the cost of the autograft. It could be the iliac crest choice better.
So, Rajeev, what you have done? Iliac crest?
Yes,
Show
I
what
will show
you've
you.
done.
So no, these are the treatment options. So approach, I think there is a second ARS question. Can you put up? So what approach? Deltopectoral, deltoid split, posterior subdeltoid, combined anterior and posterior approach.
ये क्या है? Delt. ARS question थोड़ी है यार ये.
So all right. So I think 3% of people have told posterior subdeltoid. So, Roshan, what
No,
are indication for posterior?
I have no experience with other three. I have only one.
Anyone of
deltopectoral.
expert faculty, posterior subdeltoid. When do you approach? Yes, sir.
So you praise that?
Yeah, because
No, no.
you
In
should know.
addition to deltopectoral, only on one occasion I had to open up separately posteriorly because it was just not coming out from front, and there was a lot of bone formation at the back, a kind of a extra capsular calcification. So I had to go posteriorly, split it, ease it out from there, and then get it back.
Yes. So there are two indications. You are not able to reduce it. You have to release some posterior soft tissue. Second, sometimes you have a posterior glenoid bone defect also. In those cases, you have to use this posterior subdeltoid approach. You can add it with the anterior deltopectoral approach. So I used a classical deltopectoral approach, and you see the biceps is the gateway. First, you try to identify your biceps. Sometimes it's just entangled with your conjoint tendon. So try to release it, and then go for a lesser tuberosity osteotomy, and then you fix it. So what is your ideal fixation method, Roshan? You try to fix it with a screw?
I always
with an
like to
anchor?
screw.
Screw. So
I'm a screw man.
screw. So I fix it with a, once you reduce it, you can see there's a huge defect in the humeral head. You can see a big defect there. So you fix it with a cancellous screw. I used a very cheaper option, 6.5 millimeter cancellous screw, and this is the 11-month follow-up of this patient. Hope this video runs. And if you treat them early, you can see you can get good range of motion. So that is the important point.
We have a question.
Rajeev, mostly what I have seen that it's difficult to fix this LT with screws because that head is also quite osteoporotic.
Yes, yes, yes.
You don't get a good hold there.
So, nowadays I started using endo button, especially the adjustable. Before adjustable loop, it was very difficult. One case, we had a similar problem, screw was not holding. So same track, I put an endo button, ACL endo button, adjustable loop, and then I fix it on the other side. You are absolutely right. Sometimes you don't get hold in that
Yes, yes.
area.
So I think you should always keep your anchor as a backup and adjustable loop as a backup. But sometimes because of cost, you have to compromise it, and you can add a transosseous suture also with that.
Because of the chronic nature, even the head is osteoporotic,
Yes, yes,
and the segment which you have osteotomized, that's also that
And-
bone is not so good.
And the forces, the forces, subscap,
Yes.
the strongest muscle of the shoulder joint. So it's not that easy to fix it with only one bone. You are very lucky to have it with only one screw, complete bone piece.
And second thing is that suppose you are using an allograft or autograft, then how do you fix the subscapularis back? Where do you fix it?
So if you are using an allograft or autograft, so normally what happens, you are pushing over humeral head defect. So try to put it over the part of the junction of the allograft and the articular cartilage. That is the best way you can put it.
You can fix it with the anchor, like we do a takedown,
On the
reverse or
on the native bone, not
anatomical.
Or the native
Yeah,
bone,
not
native,
on the
because
ground,
you
yeah.
can't,
or the native bone.
because already you have filled the defect.
The strongest bone is the bicipital groove. Sometime you have a problem with lesser tuberosity. I just shift my screw in the bicipital and do a tenotomy and tenodesis of biceps.
But very good point by Dr. Sekhar. Sometimes if you have a poor fixation, get ready with a adjustable loop and the anchor also to reinforce your screw. So these are the learning objective. AP and axillary X-rays are mandatory in patient presenting with shoulder pain.
Yes, we have
post-trauma
a
with
question
restricted
from
shoulder
floor.
movement, as told by Maheshwari sir. Always do NCT and MRI, because you will get lot of information about the humeral bone loss and your soft tissue, and early diagnosis as post prognosis when you see this lock.
Prahlad.
Yeah, Rajeev. So, what is anybody is having experience of using TCP? We are talking about allograft and autograft. So there was a significant osteochondral. The head was depressed. So part of articular cartilage was depressed. So we can elevate, and the void can be fixed with the kind of wedges we use for HTO osteotomy
If
and
it
all.
is a fresh case, it's quite easy to elevate the graft, but 6 to 8 weeks old dislocation, sometimes it's very difficult. But I have not used TCP. Any of the
No, no.
I frequently use it for the fractures. So a lot of osteoporotic fractures when we get.
All
So
right.
keeping the wedge is a very good option.
Good option. Dipti sir wants to add something here.
Raman, the few things, when you're doing this late, I've done them for 7 months later also. One thing you have to remember is that osteotomy should be in the plane of your base of the long head of biceps groove. So you get out exactly where the defect is anterior one. it's a big chunk. If you use a screw, one screw, there is a chance it don't
Rotate.
Yes,
Yes,
rotation
yes.
is the problem.
Subscap is a
I
huge
would
attachment.
rather use two screws rather than one screw, 1 point. Second thing, in some of the cases what I've done is when I put these screws in, the LT gets compressed down because there is a lot of erosion on the bone because of the glenoid rubbing on it. So there is a big void. It's best to use a iliac crest graft under your LT and then put your LT back on.
Good.
So it will give you a good width.
Interposition
Yeah,
grafting.
it will give you a good width of your
Yeah.
humerus.
Good suggestion, yes.
So you take a lateral view from the top and you see the humeral head. You should see a full circle.
That's a common problem. The LT goes in.
And once it goes in, you do this, it will dislocate again.
Yeah.
So it will dislocate intraoperatively. Intraoperatively, you should put it through the range.
Yes.
And I don't use these pillows, external rotation, nothing. Just normal sling will hold it. So if you are having to use the wedges and this thing to hold it, that means you are not stable enough on table.
Yes.
Last comment by Vivek before we do the felicitation.
Same questions I would like to extend. So while doing some of these surgeries, I got a problem. I got difficulty with LT osteotomy. How deep how deep we can go, or what is the width we should take? What is the length? So is there any technical nuances?
I think you should follow the bicipital groove. Along the bicipital groove, it should be at least 1 into 1 into 1 centimeter chunk, and then you can use two cancellous screw. Otherwise, it's very difficult. If it is suppose by osteotomy you see it's a very thin slip of bone, then I think you should
Vivek,
do anchor fixation.
Subscap is a huge attachment. It's almost 5 to 6 centimeter long attachment.
Yeah.
It's like tubercle osteotomy. Same way you have to go in line with bicep, in depth with the bicep.
Okay.
So it's almost around 8 to 9 millimeter deep, and is almost around 5 to 6 centimeter long. So as rightly pointed out, one screw may not be sufficient. You have to put at least two screws.
Or one anchor head.
So my final question, our aim is to cover that reverse heel sac lesion, right? So should we have some measures of reverse heel sac so that we design our osteotomy accordingly and safety it accordingly? Is there any point like that?
So you can take just the lesser tuberosity. You can't take the more bone because again you will
Yeah.
Two screw fixation, I think two screws are better because if you are considering that it is an osteoporotic fragment, if the screw is not holding, how much can an anchor hold? It's
Yeah,
really
it's doubtful.
With the stress of a subscapulary,
Subscapular.
anchor will definitely come out if you are doubting the screw fixation.